I think the one question is right now is that, should people have targeted therapy, immunotherapy, or a combination of the two, or sequential targeted and immune? So I guess those are the four, permutations and combinations that are out there. And I think there's advantages and disadvantages to each one of them. I think, what for me was one significant piece of data was that the complete responders, which is what we are trying to get for our patients, trying to get complete responses for our patients, I think that population is going to be probably 20% or less for targeted therapies, 20% or less for immunotherapy, PD-1 therapy by itself, and probably around the same for patients who are getting ipi-nivo therapy. So the issue is that the same 20% with each one of those therapies? Are they different, and can you increase that percentage if you were to combine targeted therapies and immunotherapies? And I guess one of the positions I feel like might make sense is that you could increase that percentage by combining the therapies. And if you look at the last 6 years of research on BRAF inhibitor resistance and what the pathways are, I think you could say that we don't have a really good understanding today about, at a molecular level, what needs to happen for a BRAF inhibitor, MEK inhibitor combination to give you a complete response versus to give you some kind of response and putter out or not even get a response at all. So at a molecular level, we don't understand that. I mean, at the clinical level, we know that these are patients who have normal LDH, they have fewer sites of disease, a good performance status, we know that. And for immunotherapy, we know that, normal LDH, not bulky disease, not liver metastases. I think those are the patients who tend to have complete responses. But even for immunotherapy, I don't think we fully understand today what needs to happen for you to have a complete response. We know that PD-1 is present on a lot of exhausted T cells, and when you block PD-1, you'll get proliferation of these exhausted T cells in the tumor microenvironment. But sometimes that seems to putter out, sometimes that seems to be productive. And what the differences are, you probably need help from central memory T cells. You probably need DCs to be, activated. To me, it makes sense that combining immunotherapy and targeted therapy, you might get a higher percentage, and I think that's what some of the early clinical trials data seems to indicate, that your response rates are higher. You get prolonged PFS,